want to introduce Dr. Simron Singh, who is a medical oncologist at the Sunnybrook Health Centre here in Toronto. He's, in addition to a medical oncologist, is also a master's in public health and has some interests in the healthcare system at large. He's going to talk to us about neuroendocrine tumors this morning. Dr. Singh, please.
Thanks very much for inviting me. I think that was a great talk, and I found it very inspiring. And I think I wanted to talk a little bit more on that theme, specifically in neuroendocrine tumors, involving patients and physicians together in care, and what that actually means for patients with neuroendocrine tumors. So, lots of us know this information. I mean, neuroendocrine tumors are a very unique set of diseases. They're not a large group like other cancers, like breast cancer or even colon cancer. They're a very heterogeneous group of malignancies. Part of that reason is geography. They can really come from anywhere in the body. They can come from anywhere in the GI tract. They can come from the lungs. They can come from the pancreas. And they can even come from a spot. So any neuroendocrine cells can actually grow to provide neuroendocrine cancer. They can be symptomatic. They can be asymptomatic. And I'm sure people in this room are well aware of that. They can be very indolent, and that's, I think, the tradition that we've been hearing in medical school for many years, that neuroendocrine tumors or carcinoids are indolent, but they can also be very aggressive. And again, well aware to many people in this room, they can go undetected for many years without signs and symptoms. Some of them can produce peptides that can lead to symptoms. So I think this is the most important slide I have today, and the most important message that I like to get across when I discuss sort of an introduction to the spectrum of neuroendocrine tumors is the fact that they're very heterogeneous. These are very different diseases, and I would risk to say that one doesn't behave like another. They can be metastatic. They can be localized. They can be very well-differentiated tumors, and we'll get into that a little bit, what that means, or they can be poorly differentiated tumors. And they can be indolent, and they can be aggressive. So I think it's very important to think of these tumors as individual tumors, and I think as patients in the room, it's very important to try to determine what kind of tumor you have. And so what I'd like to do today is talk a little bit about these characteristics and try to help to see how we can figure out what kind of tumor we're dealing with here, both as physicians and as patients. So why is this important for the patient? Well, like I just said, you need to really figure out what type of neuroendocrine tumor you have. I think that says a lot in terms of your treatment and in terms of where you're heading to in the future. Not all neuroendocrine tumors are the same, and I think, as Dr. Gosperich was saying, it's very important to be involved in your care, both on a global level but also on an individual level with your healthcare team. So one of the biggest challenges that I think everybody faces, patients and physicians, is this idea of classification of neuroendocrine tumors. It's changed many times. It's been an ongoing discussion. And as you can see, it's a very confusing situation. These are all lists of different tumors, neuroendocrine tumors, having different names. So as you can see, this is daunting to anybody. I don't think we need any more names of neuroendocrine tumors. I think what we need to do is have a better classification system, or at least start applying the ones that we even have right now, so that we can get a better understanding, so that when a physician and a patient discuss about a tumor, they understand what each other's talking about. When physicians and patients speak to each other, they have an understanding of what they're dealing with. Because if you can't name it the appropriate thing, you're not going to understand it. The AGCC hasn't really adopted a great classification system for neuroendocrine tumors as of yet. Neuroendocrine tumors are divided by where they originate from, and they're classified according to their spread, but it's not a very effective system. I think the system that we see most used now, at least in our institution, is the WHO classification system. And this was put together, I think, because of the need of a good classification system. This basically looks at all the important factors here and tries to help delineate the behavior of the tumor and try to separate out that spectrum that we've been talking about. It includes factors such as the biological behavior of the cancer, the metastases, something called the Ki-67, which I think is very important, infiltration, angioinvasion, necrosis, so different risk factors, and the size of the tumor. So taking into account some individual factors of the tumors to try to understand it a bit better. One thing to notice here is when they look at poorly differentiated tumors here, they've set a cutoff of Ki-67 for 30%. Ki-67 is a marker that basically looks at tumor proliferation. I think it's a very important part of understanding individual tumors. Another system that we use at our institution is the ENET's classification system. All our samples get classified according to this as well. This is something that's a little bit more familiar to oncologists because it uses a traditional TNM staging system that we use in other cancers as well. It takes into account location, knowing that there's difference between foregut, midgut, and hindgut tumors, for example. But it also takes into account grade. And grade is basically characteristics of the tumor cells themselves, including proliferation. And here you can also see this index called the Ki-67. And here the cutoff for a poorly differentiated tumor has been moved down to 20%. So I think we're having a better understanding of what, in fact, a poorly differentiated tumor is. And why is the Ki-67 important, or why is this grade important? Well, we know. We hear from many physicians that, neuroendocrine malignancies are indolent, they don't grow, they just stay there for a long time, and some of them do, and we can see that by this curve here. This is looking at survival over the different grades, G1, G2, and G3, G3 being the poorly differentiated tumors. But we do know that these poorly differentiated tumors do not do as well. They require more aggressive treatment. They require different types of treatment, including perhaps chemotherapy and other modalities. So it's important to understand the different tumors according to these different grades, because it actually makes a difference in terms of outcome. So for the patients, I think it's very important to know what your Ki-67 is. And if you haven't had this discussion with your physician, I think you definitely should at least have some understanding about what your Ki-67 is. As well, we need to know where the cancer is spread to. I think that's very important in trying to understand the malignancy. We know that metastatic disease or spread of the cancer does occur, unfortunately, at presentation, and probably a lot of that has to do with the imperfect methods we have for detection right now, and I know a lot of people in the room are working on improving that so that this won't be the case forever. And again, this does make a difference because where your tumor is can make a difference to how things are going to progress in the future. And I think that's very important that we understand, in fact, where the tumor is. Because again, I want to try to break this myth that all neuroendocrine tumors are indolent and can just be observed. Not all, some of them can, but not all of them. And I think that's very important because we do need better options for some patients. So getting up to diagnosing, we've sort of been talking. I think it's a common understood thread that diagnosis has always been a problem in an uncommon, I wouldn't say rare, but an uncommon tumor such as neuroendocrine tumors. And I think Dr. Gospodarevich's talk is incredibly important in terms of helping to educate physicians and working together, especially when we're looking at this type of tumor, because it's not common. Okay, history and physical exam, of course, I think is important. Looking at symptoms. Flushing, diarrhea, discomfort, wheezing is present in approximately 30 to 40% of patients whose disease has spread. Not all patients, but just the ones whose disease has spread. Biochemical markers are very important, and we'll talk about this in just a bit. Chromogranin A, I'm sure you're going to hear a lot about this today. And urinary 5-HIA, I think, are important biomarkers. And then there are specific biomarkers for very specific type of, for example, pancreatic cancers that sometimes we use. And imaging, of course, is important. CT scans, readily available. Arterial scans, perhaps, being something that isn't available in every institution in Ontario, but is available and is specific to this disease. So chromogranin A, it's a blood test. It's a serum marker. And it can be useful in both diagnosis and in treatment. And we do know that if sometimes as physicians, when we're providing treatment, we monitor the chromogranin A to see if it goes up, to see that the treatment's not working, or to see that it goes down to watch that the treatment is working. It's important to note one thing is that there are some things that give false chromogranin A's, so that's important to recognize and to discuss with your physician. If you're on a protein pump inhibitor like Losec or Prevacid, that's going to give you an elevated high chromogranin A, and I think that's an important thing for us all to be aware of in the room together. We also know that the higher your tumor burden, the worse the chromogranin A level can be, and that can actually be predictive of how the future is going to go as well. So that can give us, again, some idea of risk. And I guess the whole theme we're getting at here is trying to understand risk and try to understand what needs to be done to minimize that risk as best we can for patients in the room. Urinary 5-HIA, it's the 24-hour urine test that I'm sure many people have completed in this room. It basically measures a breakdown product of serotonin. We measure that to see if the tumor is, first of all, secreting serotonin and if we can have it controlled. And I think numerous studies have shown now that it's important to try to control this to a normal level and to reduce the serotonin levels, both for symptom control and for long-term outcome and complications. Ki-67, again, we talked about this. This is, I think, a very important marker. This is not something that's done in the blood. It's actually looked at in the tumor sample, and the pathologist comes up with the answer what the Ki-67 is. So this is an important. Sometimes I get referrals from other hospitals in areas that perhaps don't see so many of this tumor, and they haven't even done the Ki-67. So I think it's an important part of looking at the tumor and trying to understand it. So again, for the patients, another couple questions to really have in your mind that if you don't have the answer to right now that you should be discussing with your healthcare team is, what's your urinary 5-HIA? Are you a secretor or not a secretor? If you are a secretor, is your urinary 5-HIA controlled? And what's your chromogranin A level? So I think these are, again, important questions to keep in mind. And then the final thing I just wanted to bring up when we're talking about delineating risk is actually the care patterns. And this is something that I'm somewhat interested in. I think Dr. Gosper-Davids also talked about this, is that multidisciplinary care hasn't been shown to actually have improved outcomes. And I think nowhere is that more important than situations like neuroendocrine cancer. I think we were discussing yesterday the idea of silos of care and how they exist and how difficult it is for an uncommon disease like neuroendocrine tumor to be treated in that pattern simply because of the lack of understanding and lack of resources. So I think it's very important. Let me just explain this slide first. This is the SEER database. This is a very good paper that came out by Dr. Yao from MD Anderson last year, who looked at basically 35,000 neuroendocrine patients over the last 30 plus years. And it was all collected in a large database in the United States called the SEER database. He basically looked back and looked at a number of trends and gave us a lot of valuable information about the natural course of the disease that we probably wouldn't have otherwise understood. These were the survival levels. This is from 1973 to 87, 88 to 2004. So some improvement, okay, and then 73 to 2004. And then this is, the orange here is two slides of two specific centers that have an interest and have a level of expertise in neuroendocrine tumors, one in Uppsala, where Dr. Oberg here is from, as well as another place in Florida, the Moffitt Cancer Center. And these were both presented. I think some of it was actually presented here last year as well. But they basically show that having a multidisciplinary care is associated with better outcomes. And I think that that's important, to have a multidisciplinary approach to this disease. Now, that may not be possible in all situations, but I think where it is, we should definitely try and aspire to that. This was another study looking at the same thing, again, looking at multidisciplinary care, and it basically was in Australia. And in Australia, they found that neuroendocrine cancers were being more and more referred to multidisciplinary clinics, which include medical oncology. And you can see here from 85 to 95 in 2005 that more patients were getting referred to a multidisciplinary center. And in fact, their survival was better. And in fact, it was quite a bit better. Now, this wasn't the only reason, of course. There's been new advances and changes. But I think it does show that there is an association with multidisciplinary care, having different parts of the healthcare team and the patient work together to get outcomes, especially in uncommon tumors like this. One of the things they did come up with an idea was somatostatin analogues. When they were referred to a multidisciplinary center with a medical oncologist, the use of somatostatin analogues was much higher. And in fact, when they looked at the survival time of these patients, they found that one of the biggest factors was that they were actually using somatostatin analogues probably more aggressively than other physicians in the community were. And that actually reflected in survival. And I think that also shows from Dr. Yao's paper, pre and post 1987, we do see better survivals with distant disease, okay, which is encouraging. We're seeing an increased trend. Now, obviously, part of that's due to better understanding of the disease and better treatment options. But one of the big changes was the introduction of somatostatin analogues or octreotide, and we do find that that has been associated with an increase in survival. So I think it's important for you to know if you should be on a somatostatin analog. You're probably hear today some other data that's come about in the last year emphasizing the importance of somatostatin analogs, and I think it's very important that at least you have that discussion with your physician if you should be on a somatostatin analog. And then the last thing I think is if you can, if it's feasible, to seek care in an area with at least some expertise or interest in neuroendocrine tumors. I don't think it's feasible for everybody to go across the pond to Europe, but I think we do have centers here in Canada that have an interest in neuroendocrine tumors and have levels of expertise, and I think it's important that we engage those physicians to work with patients. So what I really want to sort of emphasize today is that basically classification is daunting, and it can be daunting for physicians, it can be daunting for patients when we have a very confusing classification system. So the quicker that we start to adopt a united classification system, the better off we're going to be in terms of moving forward. A systemic approach to neuroendocrine tumors includes, of course, a physical examination, and I think the old adage that history and physical is always the first step is especially important in neuroendocrine tumors because of the unique symptoms that we see. Biochemical markers such as chromogranin A are important, and if you're at an institution that doesn't have it available, I think you should at least have the test done. And if possible, multidisciplinary care should be used, and we should try to involve centers that have interest in neuroendocrine tumors and can provide multidisciplinary care. And I think the overall theme is that as patients, it's important to get involved in your care, especially with an uncommon tumor like this. And thanks very much.